Okay, can everybody see the presentation itself? Looking good? Okay, awesome. Okay, team, go for it.
Great. Thank you so much, Cara. I appreciate your support this morning. So welcome, everybody. We are really excited to see so many people here today. Just a reminder that today is a repeat of the presentation that we did at Full Lives. So if you were at Full Lives and got to see this, there is no new information. It is the same. We just want to make sure that we're getting this information out to as wide an audience as possible. And then we did want the opportunity to record so that we can put it on our YouTube channel for anybody who wants to watch who was not available to see it today. So the purpose of our presentation is to provide some introductory information about some system change that we are undergoing here at Senior and Disability Services. You may have heard that we are moving to the InterRAI, and you're wondering, what does that mean? So we're going to give you some background about how we got to this point and what we are changing as we go forward. We're actually changing our assessment system. And so we want to give you some basic information and an overview of what InterRAI is. Finally, we're going to talk through what it takes to launch a project of this magnitude within Senior and Disability Services to help you understand the many steps that take place. But first, we'll introduce ourselves. So Cara, if you don't mind moving to the next slide. My name is Caroline Hogan, and I'm Chief of Programs here at Senior and Disability Services. I've been here with the division for about 16 years, and I'll turn it over to Director Newman.
Hi, everyone. I'm Tony Newman, the Director of the division. I've been with the Division of Senior Disability Services for 4 years, and with the Department of Health, though, for about 23. So it's great to see everyone. I'll turn it to Lynn.
I'm Lynn Kyle-McCruz. I am the Deputy Director for Senior Disability Services, and I have been with the division for about 17 years. And before that, I also worked for the consulting company that did a lot of the assessments for the state of Alaska as a contractor. So I have a lot of experience with actually administering the assessments that we use today. But I will hand it over to Caroline. Nope, not Caroline. She already did it. To Cherry Herman.
Hi, good morning. Thanks for joining us today. I am Cherry Herman, the Project Management Unit Manager at SDS. I've been with SDS about 10 years and with the department about 24 years. So thank you for joining us today. We look forward to sharing a lot of great information with you. And lastly, our guest speaker today, Melanie Thomason.
Hi, everyone. Good morning. My name is Melanie Thomason. I'm an InterRAI Fellow and Vice Chair of the InterRAI Network for Integrated Care and Aging. I've been supporting InterRAI implementations across the United States for almost 15 years. I'm also a senior principal at HCBS Strategies, which is a small consulting firm.
Great. Thank you. So we can move to the next slide. So this is our agenda for the next 90 minutes. Of course, we're going to take a look at our mission statement. We'll have some comments from both our director and our deputy director. We'll look at our current assessment process, just very briefly. And then the bulk of the presentation is an introduction to what the InterRAI is and the planned tools for Alaska. And then we will move to a little bit about our next steps and the project implementation. So if we move to the next slide. So here at SDS, we always like to start any presentation with our mission statement. Senior and Disability Services promotes health, well-being, and safety for individuals with disabilities, seniors, and vulnerable adults by facilitating access to quality services and supports that foster independence, personal choice, and dignity. We like to acknowledge that we appreciate the people who gave permission for their pictures to be shared for our mission statement, because everything we do touches a person. And so we like to make sure that we keep that in mind with any sort of change or system that we are implementing, that this is going to touch every person who interacts with SDS. And so we want to make sure that we always have you first in our minds. I'm going to turn it over to Director Newman for some information about how we got to where we are today.
Thanks, Caroline. Yeah, hi again, everybody. This webinar is an exciting event for us because, to my mind, this is the most exciting thing that we have going on here at the Division of Senior and Disability Services right now. And it would be exciting enough if all we were talking about was implementing a new, a nationally recognized, state-of-the-art, evidence-based, strength-based assessment for people on home and community-based waivers. That's what the InterRAI is. But it's more exciting to me because of what it represents, not for today, but for the years to come. A path forward on a number of things people have wanted to see out of the state's senior and disability services system and programs. Almost from the day I started here 4 years ago, I heard about things that people wanted to see change about our system. New services, for instance, new flexibilities in the way services could be offered, more person direction and authority over how services could be fashioned together to fit a person's life, a desire to eliminate the intellectual and developmental disabilities wait list once and for all. And of course, upon hearing all these desires and dreams, of course, in my meetings with stakeholders and partners, I would go back to the team here at SDS and ask, so what do we need to do to make this or that possible? What do we need to do to bring companion services to the state or allow people on waivers to exercise their own budget authority? What would it take to eliminate the wait list once and for all? And again, I learned that the pathway toward change needed to begin with a look at our eligibility and assessment processes, and that the key toward all of these things could begin once we had a tool that made it easier and more cost-effective to allow them. So eliminating the wait list, for example. To eliminate the IDD wait list would take tens of millions of dollars if we were to simply try and provide services without any changes to the way we assess for access to those services. But if we had a tool that was readily compatible with resource allocation, we could provide a much more cost-effective means of determining the costs for services that would allow more people to be served, ultimately give Alaska's lawmakers a clear path to fund and effectively eliminate the wait list. Those of you who are active in Alaska's advocacy organizations know that this project got its start because of the desire to eliminate the wait list. Responding to stakeholder pleas in 2022, the legislature requested the department put together a plan to eradicate the wait list. We wrote that plan, and in it, we talked about how the most cost-effective way we could do that would be through introduction of a new assessment instrument. Eliminating the wait list would still cost many millions of dollars, but what I really appreciated about the stakeholders is that they recognized that we needed to start somewhere if we were going to give legislators good tools to be able to do that. And what they did was P Coalition, AADD, a number of other stakeholders zeroed in on a number in that plan, $647,800 in general fund, plus more federal authority. And they told the legislature that if they would fund that, at least fund that piece, then we'd be at least be taking a first step in the journey. It worked so well, I thought it was just a textbook example of how the legislative process can work. Advocates doing their advocacy, uniting around a specific ask, legislators responding to that ask, asking the department questions, and we there to answer their questions, provide technical assistance and details about how it would work and what we would need. It was a great partnership in a process, and it's one I hope we can repeat again in the years to come. You know, working here at SDS as director, you really become interested in system change and what it takes for major system changes to happen, since it can seem so hard. And I have found that I've become really interested in the era in the United States around the time I was born in the 1960s. I've been spending a lot of time lately reading about Martin Luther King Jr., and I've been watching an old documentary called Eyes on the Prize about the civil rights movement. Learning a lot that I didn't know about all the different strands that came together to really motivate system change. It wasn't just Rosa Parks refusing to get off a bus. It was also young people asking to be served at lunch counters, and people fighting for voting rights, for university admission, for fair places at public schools. All these different strands, and yet they came together under the leadership of Martin Luther King and his recognition that a tool was needed to succeed. And that tool was nonviolent protest. And it just reminds me of all the strands of desire that we have and that people have expressed around the desire for flexibility, desire for autonomy, desire for change. And I think about this tool and all the potential for change that it represents and its ability to bring these strands of desire together. I want to be clear, and acknowledge I'm thinking way in advance, and maybe my head is way too high up in the clouds. We are a long way from being able to implement the changes, right? Introducing the InterRAI does not mean that the waitlist will be eliminated right away, for instance, but it does at least point us in the right direction, and that's significant. And that's why this is such an important and exciting initiative to me. SDS is fortunate in that we've had several champions here who've wanted to see this system change occur for years. Caroline is one of them, and I'm so pleased that she is heading up this initiative. Another champion has been Lynn Kyleman-Cruz, our deputy director, and I wanted to thank her for that effort and turn it over to her to make any remarks she may have. So, Lynn.
Thanks, Tony. Can you guys hear me okay? Yeah. I appreciate your comments, Tony, because I think, you know, working in this field for a lot of years, working with people that experience disabilities or elders, has been a slow progress, maybe not enough progress at times. And when I was working for SDS and had gone to a conference back in DC, Washington, DC, that Millbank Memorial Fund paid for, and it was really about promoting health. At that point in time, you know, we were involved. I was involved with the waiver as a waiver program manager, and really felt like this could be the impetus that would get us to a more person-centered, flexible system. And why they chose to bring us back to DC was to talk about the InterRAI suite of tools and what it could do for systems on the continuum of care. And so it had a lot of the researchers from the InterRAI were available to us in the room to ask a lot of questions. And I was very inquisitive and asked a zillion questions and came back so excited to Alaska, like, this is what we need. And it just wasn't what I say, it wasn't ripe at the time. It wasn't, there wasn't enough momentum. We were working on other things. So, I spent my own time, went back to Michigan, where one of the actual researchers worked at the University of Michigan, and went back to see family. And I went to the University of Michigan, met up with him, talked about the InterRAI again. We had lunch. He directed me to some software vendors that I went to, that I saw how they had implemented the InterRAI, and I was just sold on it. And I came back to Alaska again, and I was like, we need to do this. And we did end up bringing them up to virtually to show to the department at the time. And for various reasons, again, it just wasn't the right time. And so in 2016, we invested in a study because we know that we wanted to change the ICAP. We wanted to change the CAT tool. So we invested in a study that studied a bunch of different assessment tools. Some of you may have been on that committee, brought it back. They did a survey, they brought it back, and they chose the InterRAI assessment. So it showed that I wasn't too crazy in my, quest to make this happen. And we began in 2017 to really look at and started doing the home care assessment tool. And we entered into contract with that same individual, Brant Fries, and his colleague, Mary, to come to Alaska and walk through sort of what it would look like for us to implement that tool. But as all things happen in Alaska, sometimes it just still is not the right time, because we were mandated at that point in time to sort of change our limited resources and focus on building out the community first choice services and the individualized support waiver. So it just sort of fizzled away our work on this. So I just wanted to bring all of that up to show that how long it has taken for us. I mean, I've been consistent in my desire to see this change happen, because I think when you see and talk to Melanie today, you'll see all the ways that I think the tool will be very, very good for Alaska and for the people we serve eventually. But again, it will demonstrate that it does take time. I personally wanted to thank everyone that has advocated for this with the legislature, because they gave us the seed money to get this project initiated again. And I just think it is, as Tony mentioned, is a really good effort that we've partnered with people to be able to push this forward. So appreciate that time, and all of the time that I've spent doing assessments and looking at assessments and really feeling like this could take us to the next step. And we're at the very beginning stages, but it is very exciting to me. So thank you. I'll turn it over back to you, Caroline.
Thanks, Lynn. So next slide, please, Cara. So as Lynn mentioned, these are the tools we currently use. The Inventory for Client and Agency Planning, called ICAP, or the Consumer Assessment Tool, which is known as the CAT. SDS administers 5 home and community-based waiver programs. Waivers are for people who meet an institutional or nursing facility level of care, but they want to receive services in their own homes and communities rather than in one of the facilities. Folks must be Medicaid eligible. SDS also has services available through Community First Choice option, which also requires that people meet at one of these levels of care. And then we also administer a state plan personal care program, which is for people who meet Medicaid eligibility, but not necessarily a level of care. But they do still demonstrate a need for assistance with activities of daily living, like eating or bathing, or instrumental activities of daily living, like shopping or laundry. So to determine if somebody qualifies for personal care or hours, or for a nursing facility level of care, we administer the CAT. And to determine if somebody meets an institutional care facility for individuals with intellectual disabilities level of care, we administer the ICAP. Can we move to the next slide, please, Cara? So we've used these tools for many, many years. And although they have served us well, it is time, and as Lynn said, and I support this wholeheartedly, it's time to modernize our system and move into the future. Some of the challenges that we have faced with our existing tools are that our CAT is homegrown, and the ICAP is at this stage getting a little outdated in its language and questions. We use different tools for different populations. There's different training requirements because it's different tools for different teams of assessors. We're unable to use our tools to compare across populations, and especially nationally with other states. And we're also unable to use our existing tools to build on emerging science to inform resource allocation, eligibility decisions, or other operations. So a standardized, scientifically sound assessment will allow Alaska to develop processes to expand participant-directed services and expand the range of services available over time. So we're very excited about what the future holds for us. So we'll move to the next slide, and I'm going to turn it over to Melanie to talk about the InterRAI.
Thank you so much, Caroline. Next slide, please. All right, so what is InterRAI? InterRAI is actually the name of a nonprofit international research collaborative. We're all committed to improving the care of individuals who have disabilities or who are medically complex. And we do that through developing these scientifically sound, comprehensive assessment systems that can be used both to fully understand really well a person's situation, as well as to help indicate how to translate that information into an appropriate care plan for the person. We design and implement these systems around the world. We are actually currently in use in about half the US states and more than 35 countries globally. So it really is a pretty robust community if you all join, as you all join the InterRAI community internationally. We have been around quite a while. We actually got started in the early 90s in the United States when Branch countries, who you heard about earlier, realized that he was working on the same problem that some researchers in other countries were working on, which was how to develop a standardized, valid way to assess people in nursing homes. And so that first InterRAI tool actually became the MDS that is still in use in American nursing homes and also in use in many other countries as well. So we develop these systems, we develop the applications for the systems, and I'll talk more about that. And we provide the licenses to use them to governments, vendors, and care providers around the world. You can learn more about InterRAI as the organization, as well as our various tools that I'll be talking about today at our website, interrai.org. Next slide, please. So when people first learn or first hear about InterRAI, a lot of people think it's some large corporation. We're very slick. We're very, smooth. Maybe high dollar. If you go to the next slide, the truth is a little more practical. Next slide, please. There we are. We're actually, most of us are researchers. Many of us are academics. We also have clinicians, we have policymakers, we have direct service providers. We have people who have been trained in how to psychometrically develop these valid systems and who want to use that for the greater good. And so this is a meeting from a couple of years ago, but it's always fun to get together. It's always a lot of work to get together, but InterRAI systems are, a labor of love. We are always developing new applications. We are always improving, and always trying to make sure that the tools that we create are the very best for the purposes that they're developed. The specific tools that Alaska is considering using, I'll address those when we kind of get to that part of the presentation. Next slide, please. So what makes InterRAI assessments different? So first of all, there aren't a lot of really well-developed, validated assessment systems that are used across jurisdictions and that are intended to show a very full picture of a person. But even when you compare against the few that are out there, we are quite different. We're not just an assessment. We're not just a form. We're certainly not a questionnaire. We're an entire system that includes instructions about how to gather the information from multiple sources, how to make sure that information is the most valid. We include manuals that kind of lay that out very clearly, have training standards to make sure that we are collecting the data in objective and consistent ways. We include applications, and so it's not just the good quality of data, but some instructions on how you can use those data. And so I'll be talking a little bit later about scales and caps, as well as some of the other applications that InterRAI has developed. They're proven valid and reliable. So on the interrai.org website, you can actually see our bibliography if you're interested, if you're a little wonky like that. We have literally hundreds of peer-reviewed research articles proving how solid the science is behind InterRAI assessments. As I mentioned, we have lots of great outputs that are very useful, that can be used to directly inform care planning, and we're used across the United States and internationally. Next slide, please. So this is the InterRAI suite. So InterRAI has developed these assessment systems that are kind of geared towards specific populations. However, they are compatible. So when we have things that are relevant across groups, we are making sure that we're measuring those in consistent ways that allow for true apples to apples comparisons. So the home care instrument, which is one that Alaska is considering and is the most commonly used in the United States, is primarily for adults with physical disabilities or age-related impairments. And we have a number of directly compatible things for similar populations. The contact assessment is a very brief screening instrument that can be used for that population. The checkup is a comprehensive instrument, but more streamlined. So we really have a number of different instruments. We have a full community mental health suite, as well as instruments for people who are in institutional care with mental health or behavioral health issues. We have an acute care suite that also includes an emergency department screener. We have an ID suite, and so we'll be talking about that today. That includes instruments across the lifespan for people with IDD. We have other children's instruments as well, specific for kids with maybe complex medical conditions or other kinds of developmental concerns. We have a brand new baby and toddler instrument, the early years 0 to 3. We really try to kind of capture across the continuum of care. And if you go to the next slide, please. Another way to visualize this idea that we have all of these different instruments is that they do have significant overlap. So when you have something like the ability to perform activities of daily living or instrumental activities of daily living, like Caroline was talking about earlier, those are relevant across groups. Now, for children, you might be talking about like some developmental, some age appropriate expectations there. But when you're talking about how well someone is able to, get around their house, can they walk around the house without assistance, or what level of assistance do they need? Are they able to prepare their own food? Are they able to eat on their own? These are things that are important regardless of what the nature of your disability is. And so we have developed items that have been validated so that we can make sure that we're measuring that in the same way across these populations. Next slide, please. So we have, as I mentioned, tools across the age continuum. For people with intellectual or developmental disabilities, we have the ID tool for adults aged 18 and above. For the Chime DD, we have, for younger people with IDD, we have what's called the Chime DD tool. That's for ages 4 to 18, though it can be used up to 21. And then we have that new infants and toddlers instrument I mentioned, the early years. Where this becomes, especially for folks with IDD, this is invaluable. To be able to use instruments that are compatible across the lifespan, you're really able to see how someone is changing over time or not changing over time, and able to take that into account as you're developing care plans for a person. On the physical disabilities and older adult side, we have the home care instrument, the HC, for age 18 and above. We have what we call the PEDS HC for age 4 to 18, and then the early years would also be relevant for that group of folks. And so again, we're really making transitions of care much simpler than when you're not just changing programs, you might be changing instruments as well. The situation, states that have programs set up like that often have a lot of difficulty at those transition times. And so this kind of supports that, those lifespan changes. Next slide, please. So as I mentioned, we're not just a form. It's not a questionnaire. It's not just something you tick off. We're a full system. And so for every InterRAI system, it has a manual. And so because I always have my manuals around. Here's an example of a manual. The manuals are designed in such a way that they go through in detail each of the items that's included in the instrument to make sure that whoever is doing the assessment really understands how to approach the topic, how to ask about the topic, how to record the information in a way that assures reliability of those data. So we have the manuals. InterRAI systems are also supported with software. So InterRAI doesn't produce the software. InterRAI licenses software vendors who then computerize the InterRAI system so that it can be collected. And then we have training. So there's a question about who's qualified to give this assessment. So different states set different standards for who should be the assessor, but when it comes to knowing what training is effective and what training gets you to that, inter-rater reliability that you need and want, InterRAI does have clear guidance on that. So there's information in the manuals that really steps someone through how to approach this, not just doing the assessment, but learning about the assessment. There's standardized training that's available through an online platform called Relias that's been developed by InterRAI fellows. There's also training that can be done face-to-face in person by experienced InterRAI trainers who have done this, across the country, and so training is a big part of this. If you don't have good training, you're not going to get good data. InterRAI assessments, many of them can't, many states choose to use clinicians as their assessors, but it certainly doesn't have to be that case. InterRAI has seen a lot of very successful implementations with folks who may not have direct clinical experience, but maybe more applied social work type experience that may not be clinical in nature, or people who simply have had some experience with these populations and go through the rigorous training approach to make sure that they are collecting the information well. InterRAI also has a good deal of experience with helping states think through how to monitor data quality on an ongoing basis, and I know that that's something that certainly Alaska would have in mind, I would imagine. Next slide, please. So applications. So InterRAI has, you go through all this process, you do this rigorous assessment process, you get good data. So now what are you going to do with the data? So InterRAI has this idea of measure once, use many. So let's get as much good out of these data as we can and use them for as many different things as we can. And so InterRAI has developed what we call algorithms. Now, I'm not talking about AI, so don't worry about that. These are old, this is what we called algorithms back in the day. So these are sets of decision rules that use the InterRAI data in such a way as to produce an output that's useful. Right. So some of these things that we develop are scales. So we have scales that can characterize people in terms of their functional ability, or whether there might be any concerns. We have scales, for instance, that flag when there's a risk of a fall, or a risk of an ED visit, or scales that flag when someone might be at risk of abuse or neglect. We have scales that characterize a person's abilities and strengths in terms of their performance of ADLs or their cognition, scales that flag things like behavioral concerns or depression or mood issues. So we have a lot of scales that do this summarizing of functioning. And then we have the scale, and then some of these can also be used to flag concerns, to identify things that need to be addressed, like pain, like social withdrawal, and then you have a special kind of scale, well, it's not really a scale, but a special kind of algorithm used for person-centered care planning called a CAP that I'll be talking a little bit more about in depth, because those are really special and very unique to InterRAI. We have algorithms that can help with monitoring service quality. We have quality indicators developed and validated for the home care tool. We actually are currently, our researchers on the IDD side are currently working hard on getting some validated risk-adjusted ones on the ID side as well. We have some scales that can be used for screening. So things like identifying when people may be in need of personal services, people who might need assistance with activities of daily living and decision-making, people who might need to be put at the top of a prioritization list because maybe they're kind of in a more vulnerable situation. Some of these scales are used in some places for triaging services or prioritization of services. All of that is very much the state's decision. InterRAI simply produces these tools, explains them, lets states decide what they want to do with them. We also have algorithms that can be used to inform budgets and resource allocation and things like that. So what we call case mix algorithms. So both the HC and the ID, as well as the CHIME-DD children's tool, all have validated case mix systems, which are a way of characterizing people and understanding, in general, their relative resource needs relative to other folks. Next slide, please. So in addition to all of these research validated grounded algorithms that InterRAI has developed. States all the time they're use InterRAI data to do more. So they want to do something maybe that's specifically relevant to them. That's not something that's a standard that would be national or international, but is specifically important to reflect their policies, their regulations, what they want to value. And so some of these things that we see states using InterRAI data for are developing custom screeners or prioritization criteria. So you could potentially kind of, if you want it, depending on how you structured your assessments, you could potentially use it to identify people who need services more quickly than others. States often use them for level of care, or either on the nursing facility level of care side or ICF-IID level of care, other kinds of eligibility. A lot of times these criteria are such that it is a simple thing, pretty usually, to find some good validated matching with the InterRAI system. Service planning. So states can, InterRAI never advocates for automated service planning, but states could certainly have, create an algorithm that makes a flag that if someone looks like this, then let's say maybe they score really high with the caregiver. We have a caregiver burnout algorithm. Maybe they're scoring really high with the caregiver burnout algorithm, and maybe they have some other characteristics. Well, maybe we want to think about respite. So those are all very state-specific decisions that are made based on the goals of the state, the ability to do things, and what the state wants to do. But states can decide to build these things in with their InterRAI data if they want to. Participant education and engagement. So it's always nice when you go through some kind of really rigorous medical, well, this is not medical, but rigorous testing and assessment, that you get something back at the end, right? So that you actually feel like you got something out of it. Well, some states decide to use the information that they gather with InterRAI to create some kind of a summary report for the individual that's written at their level for them to understand and get some good information out of this as well. I've seen some, actually not states, in Canada, there's some programs that have really created, reports that also give ideas about how they might do things to improve their situation themselves. And so there's really a lot of different ways that states and other governments can decide to use InterRAI data. Next slide, please. So the CAPs, collaborative action plans or clinical assessment protocols, depending on which assessment system you're talking about, they have different names sometimes, but CAPs are specialized algorithms that flag when there's an issue and when something can be done about the issue. And then they give some guidance on what can potentially be done. So there are CAPs for all of the HC, the ID, and the Chime DD tools, as well as many of the other InterRAI assessment systems as well. And so I'm going to kind of give you a little bit of example of one of the CAPs. And again, this is not automated service planning. This is simply a flag that says something is going on, and it's something that could potentially be addressed and improved, right? So, or you can prevent decline on some of them. So if you go to the next slide. All right, so an example of this is the communication cap. And there's actually a communication cap for the HC as well as a communication cap for the IDD or the ID tool. And so the purpose of the communication cap, though, is to identify people who have some severe communication problems, looking both at expressive and receptive communication, and to help to flag when that's going on, when the underlying conditions or barriers might be able to be addressed. And so this is really important. So communication problems are very common in all of the populations we're talking about. They increase the risk of abuse. They make it hard to get your needs met. And impact quality of life, right? So this is a really important thing that we need to address when it's present and when something can be done about it. And so InterRAI has identified through research what folks who have communication problems have modifiable situations. So that's when this cap will flag. It'll flag when there's a modifiable situation going on, and the There is a separate manual for each of the caps, or for the caps for each instrument. So within the cap manual, it gives you specific information about how to actually process this. So a cap's been flagged. Now what do? It leads the service planner through step by step how they should think about identifying these barriers and what they can potentially do about them. And so the goal in particular for this communication cap is to engage the families, engage the caregivers to help promote and support that effective communication so the person's needs will be met, and to minimize it. So for some folks, you won't necessarily be able to improve their communication, but what you can do is you can minimize the negative impact that communication issues may have on their integration and community engagement. Next slide, please. Okay, so I'm going to walk through a little bit more on the specific tools that Alaska is considering. So next slide, please. So the ID tool, the intellectual disability tool, this is a comprehensive and standardized person-centered assessment. So like I've mentioned, the items are developed in such a way that they get that with the training and with the understanding of the intention of the instrument, they give valid and reliable data. So those data are going to be reliable across assessors. That also allows you to track someone how they're doing over time in a reliable way. So it's not just an issue with the measurement if someone is showing change. It includes not just, I know I've been talking a lot about impairment, but this also includes information about a person's strengths and a person's preferences, as well as their impairment and level of need. The ID has been developed for use with adults who are age 18 or above with the IED, and it can output caps, scales, and a case mix out. Next slide, please. So I'm not going to keep repeating this, but these first two bullets are the case with all of the instruments that we're talking about today. Comprehensive, standardized, person-centered, measuring needs, strengths, and preferences. And there was a question about where this is being used currently. The ID in the is actually being used in several countries around the world. In the United States, it's been fully implemented in the state of New York for many years, which, as you guys know, is a huge state, so it's almost like a country in of itself. We've also we are also working on implementation in Kansas, Nebraska. They are starting. They've started collecting it with a program in Oklahoma, and we have about 5 other states that are kind of in similar stages as you all, considering it very closely for their populations. Part of this is the way that assessment for folks with IDD has evolved in the United States. It's been a little bit slower for folks to focus on the need for standardized assessment there. And now that there have been some more federal regulations and things like that to really kind of shift focus there a little bit, we're seeing a lot more interest. Next slide, please. So this gives you an idea of the breadth of the instruments. So these are all of the topic areas that are included in the InterRAI ID. So you kind of have basics, identification and demographics, things like that. Community and social involvement, strengths, relationships, supports, lifestyle, environmental assessment, communication and vision, cognition, health conditions, independence and everyday activities, oral and nutritional status, mood and behavior, medications, supports and services, and then diagnoses, discharge information as relevant, and assessment information. And so it really kind of runs the gamut. And this isn't intended to be, as I mentioned, it's not a questionnaire that has to be followed didactically. It's really intended to be an interview-based assessment approach. And so this shouldn't feel like you're being put through the ringer as you're going through this process. The other thing that I want to mention here is that while these categories or domains are named this for the ID, they might be named something different in other instruments. And so that doesn't mean that the items within it are not comparable, just that this is how the ID authors kind of positioned the content within the InterRAI ID. Next slide, please. So the CHIME-DD, so CHIME-DD actually stands for Child and Youth Mental Health and Developmental Disability. Even though it has mental health in there, it is a developmental disability instrument. It does have some items about mental health because that is often a co-occurring concern for children and youth with IDD, but it is our DD children's instrument. So this is for ages 4 to 18, but it can be used up to 21 to kind of help with that transition into the adult programs. There's an additional adolescent supplement that's available for age 12 plus that kind of looks a little bit more specifically in some of the concerns that might arise during adolescence, really making sure that we're supporting that kind of, tender age. Like there's a bit more around social interactions to identify issues with bullying and things like that. There's some suicidal ideation flags and things like that. And so really the CHIME-DD, though it has kind of the core, it has a lot of the same core things as the ID tool does, some of those IDD specific symptomology items, things like that. But it also has a lot more about like school engagement and, social things that are written a bit differently because they're designed for children. And so this is, it's a very comprehensive instrument looking specifically at these kiddos. And this tool is actually developed and validated for both community use as well as folks who might be in a institutional setting. Next slide, please. So here you can see the domains that are covered by the CHIME-DD. I won't read all of these out, but you'll see that thematically there's a lot of similarity here, where you have some things that might stand alone here, like stress and trauma. That wasn't a standalone domain for the ID. There's just a little bit more questions around that based upon our experts who work in children and adolescent health, thinking that finding through the research that we need a little bit more detail there. And so you can see here, though, this is again a very comprehensive, wide view of the individual. Next slide, please. So the InterRAI home care is, as I mentioned, this is for adults with physical disabilities or older adults who might have age-related impairments who are living in the community. This is the most commonly used instrument in the U.S. So about a little more than roughly half the states use this, and so it outputs cap scales and a case mix system, just like the previous instruments do, to flag the situation specifically of interest for these groups. Next slide, please. So here you'll see that this is a little bit more medically focused in terms of how the domains are worded. That is kind of a function of these folks being typically much, more medically complex. We have a lot of interplay between HCBS, home care for older adults, and nursing facilities and things like that. And so we really have a lot of comparability between this instrument and the MDS that's used in U.S. nursing homes, which is a really nice thing when you have people going between those two settings. But you can see we do have a good broad view here, and so again, we're getting a pretty complete picture of the person. Next slide, please. So here are some outputs. So I mentioned, the applications, the outputs, the algorithms. We have a lot of scales and such that come out of each of these. Some scales are specifically developed for one instrument. So they may not be applicable, or they may not be able to be calculated with another instrument, while other scales are kind of core scales that you're going to be able to see calculated in the same way of this instrument. So the home care and the ID tools both have, and this is just a snippet. There are many scales, but both of these instruments have the ADL, or Activities of Daily Living Hierarchy, the IADL, or Instrumental Activities of Daily Living Hierarchy, the Cognitive Performance Scale, the Communication Scale, the Aggressive Behavior Scale. But then they also have some scales that are of specific interest for that particular group. So the home care has the Changes in Health in Stage Disease and Symptoms and Signs scale, which is closely correlated with risk of hospitalization, institutionalization, and death. We have a falls cap, which triggers and gives some ideas for intervention when someone is at risk of a fall. On the ID side, a couple of examples of unique scales are the social withdrawal scale, which really is as a special concern with community integration needs. A meaningful activities cap that kind of helps you identify when someone might need some assistance, connecting with what's meaningful to them and finding the opportunity to engage with that. And the social relationships cap, which similarly, you can see we have a theme here, really supporting that integration with their community and their caregivers. Next slide, please. All right, so here I'm going to, I'll stop and hand it back to Caroline.
Thank you so much, Melanie. So Cara, let's move to the next slide, please. So we have a lot of work ahead of us. So in this slide, I was just going to touch on a general approach that when you were adopting new instruments. And with the InterRAI, this is what we're planning to do. So the first steps is we will be comparing our existing tools and identifying what's necessary to replicate the eligibility that we currently have in place. So there'll be some work that we'll be doing to do that. We also want to make sure that we can use the InterRAI to, which it certainly can do. So we just need to be able to program it this way in our software system to calculate personal care hours. Now, an advantage that we're really looking forward to is in our current system, if somebody is on an intellectual and developmental disabilities waiver, an IDD waiver, and they want personal care hours, they would have to undergo 2 assessments. The ICAP to determine level of care for the waiver, and then the CAT to calculate PCS hours. With the InterRAI suite, we would have the ability to calculate personal care hours no matter which tool we're using. And so we're very excited about an opportunity to streamline things so people don't have to undergo 2 assessments in order to get what they need. With this project, we will be having a training infrastructure in place. We will need an IT system which can house this software, and we will be assuring that we have accurate data collection and reliability. So a lot of testing along the way. We will begin assessing participants. We would start with people getting their InterRAI at the reassessment stage. And of course, as we're launching this project, we'll be carefully monitoring the data quality and the impact on individuals. And then as we look towards the future, and when we start gathering data, and this is a multi-year project, so that's where I do want to reassure people, some of this is not happening tomorrow. It takes stages to get this done. But as we go forward, we would want to use our Alaska data to look at the registry, look at DD eligibility and our level of care policies and resource allocation. So there's a great opportunity with this modernizing our system to see what other benefits we can bring about for the people that come to SDS for supports. So of course, throughout the process, we will be monitoring our processes and hoping we want to minimize disruption. And we also will have regular check-ins with you all to let you know where we're at with the project. Lynn spoke earlier about, wanting to do this InterRAI adoption for a long time and how the times weren't right. One of the things I think is really there's a lot of things coming together that's making the time right now. And one of those things is that we have a project management unit now. Our project management unit is in existence only a short number of years, but I cannot imagine adopting a project of this magnitude without their support. And so I really appreciate that we have our team on board who can help us navigate this. And so I'm going to turn it over to Cherry Herman, who is the project management unit manager. And Cherry, if you can talk through what that process is going to look like for us. Thank you.
Thank you. Boy, that's a lot of great information, a lot ahead of us. And what I intend to do, if you go to the next slide, is kind of talk in general terms about the life cycle of a project. And as it relates to the InterRAI project, as you've heard, it is a multi-year process. And so this graphic kind of shows the basic stages that we will pass through as we move through planning and initiation, design, development, and execution, and eventually to project completion. Next slide, please. So project initiation. Activities include collecting all the information about the project, goals, timelines, scope, budget. You've heard some narrative about the budget surrounding this project, as we also seek federal assistance with that. We have a project charter that kind of lays out the groundwork for this project and the draft outline. Relationship building. This activity is really an example of that, and the numerous we have already done and will continue to do throughout the project is continue to work with sponsors and stakeholders and other folks that are involved with this project as we move forward. It's a very key element throughout the life cycle of this project. And most importantly, the CMS federal funding approval process. This is where we are now. We're developing documentation and finalizing to request federal funding for this project. As a key element to this project and to the success of this project is partnering with our federal partners. And once we've achieved federal funding and approval, we move into the planning stages. We will outline our tasks, we'll set up the project, we'll line out our priorities and our targets, goals, budgeting once again, making sure that we have planned appropriately and are managing our funds correctly as we go through this process. There'll be a vendor selection, which is very important during the planning stage, a request for proposal. You've heard us say that there will be a vendor for technology to support this project. And that's the focus of my team's work, is working through that process and getting a qualified and highly experienced vendor to support the technology for this project. And then at the end of project planning, we will hope to have a vendor selected. And then we go to the next slide and project initiation. This is the design, development, execution. This is typically the longest phase of any project. This is where the magic happens. Everything's moving along. We have a vendor on board. We're doing requirements gathering. We are looking at our resources within the division and the department, managing efforts to make the milestones that we have set out for ourselves to make sure the project remains on schedule. Quality control processes, you've heard that. There's plenty of those in this phase of the project too, to make sure that the tasks meet the project objectives and the outcomes. And our software vendor is meeting our expectations and our objectives as indicated in their contract. Again, more communication with stakeholders throughout this project life cycle. Plenty of opportunities to be coming towards you all in that avenue. And then we adjust schedules because, you know, things happen between plans. Projects are all about maneuvering around objects that kind of get in the way and trying to figure out the best approach to get through them. So there will be adjusted schedules and plans, and then we're poised for those remediation tasks and change management within that cycle. Project closeout and completion. This is the end result of having achieved implementation, a software vendor that is on board and has a system all prepared and implemented for us to support the InterRAI assessment tools. We have contracts in place. We've got budgets and finance tasks set out for us, on all of required documentation to make sure we're in alignment with our project objectives at the state level and at the federal level. We conduct a post-project evaluation that includes stakeholder feedback and internal review, and then making sure that the product that we have implemented is meeting our objectives. There's a post-implementation review process there as well. And then ultimately we sign off and accept the product, which is the vendor software system, and the project continues on into what we call maintenance and operations at that point. That's the basics of a project life cycle. You've heard there's a lot that goes into this. The software vendor is the tool to implement the project, but there is a bunch of activity and a lot of information and tasks to accomplish along the way. So we look forward to the journey with all of you. And if you have questions about the project management piece, please reach out. Caroline, back to you.
All right, next slide. which is an opportunity for people to ask questions. And I really appreciate that. I think we've gotten most things covered from the chat. But Cara, we could stop sharing, and then if folks want to come off mute, raise their hands, come off mute and ask any questions, we'd certainly welcome them.
Thank you, everybody, for a great presentation. And you're welcome to go ahead and share questions if you would like. You could share them by writing them in, which if you're in the session, you can see the Q&A, and we'll answer new ones too.
Okay, so I see a question about how the new InterRAI assessments would impact the service level computation charts for personal care recipients. So that's definitely looking into the future. We are planning on the InterRAI assessments being able to calculate personal care hours. And so, of course, we would be informing people through their service level charts what those hours are. But it's, I mean, we're really hoping to mirror very closely how it's calculated in our current system. We're not planning for drastic changes there. How are community input going to be considered? How can recipients provide feedback? What about the agency providers' feedback? So definitely, as we talked about, it is a multi-year project. There's going to be many stages along the way. And we are planning on doing outreach at various intersections. So as soon as we have updates, then we would be reaching out again and doing more webinars. We are right now developing a simple one-page brochure that we plan to send out to every recipient of services in the coming month, which really just brings attention to recipients that we're having some system change coming, and we're bringing on a new assessment tool because we want to make sure that we're spreading the word to everybody who will be impacted by this. So like many of us have said, we're very early in the stages, and of course we will be having more sessions where we'll be inviting comment. In the future also, we will have an email inbox designed for this project, and we will be sending that out in a couple of months. Once we're a little bit further down the road. I say a couple of months, maybe I'm a little optimistic, but as we get further down the road, we will have an inbox dedicated for questions, comments, feedback for this work, so that we have one dedicated spot to kind of house that and make sure we're able to respond and answer. And if we're not able to answer that, we can develop answers for you, make sure we're considering everything. Let me see.
Caroline, do you want me to take the next question so you can save your breath, or do you want to keep going?
Yeah, I apologize. I'm getting over a sinus infection, and so I've been trying not to cough. Thank you, Lynn.
Yes. So the next question is it also sounds like more individuals will be eligible for services through the new assessment system. And that is not necessarily true. That is the point of actually working with our very smart mathematicians and other folks at with InterRAI, with advancing InterRAI, to make sure that we are not losing people out of eligibility, but we're also not increasing a whole bunch of people with eligibility because we don't have the authorization for that. As we talked about, like eliminating the wait list would be very expensive. So if we were to change the eligibility and add more people in, we wouldn't be able to do that without some bigger changes through legislation. So at this point, we're trying to hold the status quo, and that takes some careful calculations behind the scenes. And then the next question is it safe to say that the algorithm will determine service levels? Melanie, did you want to try to take a chance at answering that?
So I think that this is another one that that Alaska hasn't made any decisions about, but so I'll talk a little bit more generally. States can decide to apply InterRAI algorithms however they want. InterRAI, though, if you're talking about our case mix algorithms, the way that those are designed is not to say this is the right budget, but rather to say someone who looks like this on average, uses about 30% more resources than someone that looks like this. And so that gives you kind of some benchmarks that you can then apply your data and data, data specifically to your situation to figure out what kind of makes sense. But there are a lot of other decisions that have to go into that. And so, as far as like case mix system development is a very complex thing. It's something that you want to do carefully. You want to test it. You want to see what impact it's going to have on folks. You want to try out different ideas of, whether you are choosing for a single number, whether you're choosing bands, whatever you're doing. So states really approach this in very different ways, depending on their goals and their budget realities. And so as far as what Alaska is going to be doing, I think that it's too premature to say that the algorithm is going to determine service levels. I think that this gives you guys the tools you need to have science, back up some ideas about that. But what you do with that, Lynn, is up to you all.
Yeah, I agree. And I think that is the point that I hope people understand when Caroline says we will have a lot of back and forth. We will. What we're trying to do is at least hold the status quo and not harm individuals by their service levels or their eligibility to our programs. That we cannot do. So we want to go at least that far. And that takes, like Melanie said, very careful calculations behind the scenes to figure out what how we apply it and what we choose to do. So hopefully that helps.
And then if I may just add to that, like you said, but to get further beyond that, beyond making sure that we're caring for the people already on the waiver, the exciting thing about this tool to me is it'll just give us a much more refined ability to be able to tell the legislature, want to eliminate the wait list, the 400 people on it now, we have a much clearer sense of what that will cost. If you want to eliminate half the wait list, we have a much clearer sense of what that will cost. So like we've been saying, there is no plan, there's no ability to do that right now. We don't have the resources, but again, this tool puts us in a better position to give the legislature more information for the decisions it would make to increase eligibility, expand the waiver. So thanks.
I appreciate that, Tony. And also it's good for people to understand that you don't just implement the tool and then suddenly make the changes. Like you have to implement the tool, which is why we do that side-by-side comparison, because we need the data to tell us where people are, how it's being administered. So it takes a while to get to that point. So we're in the very preliminary stages now. So we always get these really good questions though that help us like think about the future, but those are really pretty far off in the future. So we'll have a lot of opportunity to engage with you all in between now and then. And Tyler's question is, at some point, I would love to be able to actually look at the instruments themselves. Can those be shared? And I responded earlier, Melanie, to say, no, those cannot be shared because they are proprietary, though you can get the concepts behind the tools themselves by looking at the website or by asking questions from our team. Would you agree with that, Melanie? I just want to make sure I said that correctly.
Yes, so InterRAI has pretty rigid rules around sharing electronic copies of the instrument and that kind of thing. I will say the instrument is available for immediate download if you want to buy it from our website. We may also be able to chat, Lynn, about some ideas that would allow for some kind of maybe in-person review of the tool. I know that's been done in some states.
And then outreach or public comment based on regulation change. So I think, Christine, you're asking if we are going to do like stakeholder engagement or just public comment. And I think we're doing both. We will be doing both. Probably you'll get sick of hearing from us, I would say. And if that's not your question, please clarify it in the chat. That would be great. And Janelle asked, can we get a heads up as letters are sent to recipients?
Sure, I think we could do that. That's a good suggestion, Janelle. We would probably the best way for us to do that would be via e-alert, and we can attach the document that's going out to everybody. Again, that will be probably about a month because it's a lot of envelopes to prepare. But yes, that's a really good suggestion, and we can do that. Thank you.
And then Christine asked, so is that SDS's intention? I'm not sure what you're referring to, Christine, if you could clarify that. And how does Harmony intersect with the process? That's a good question. So currently our assessment tool for IDD is completely outside of Harmony as it is now. And the CAT assessment is done through the Harmony project. So in the future project, if it's a different provider, again, we haven't selected a vendor, we haven't even begun that process. It would probably be just as it is today for the ICAP and be done outside the system. We'd upload the results to the system. That's as much as we know right now. Do you have feedback from recipients, consumers on their experience of this assessment process? Is it user-friendly? I'm assuming that would be for Melanie.
Sure. So there have been a number of different studies around the world that looked at the acceptability of InterRAI instruments, and you can find some of those on in the bibliography, or you're welcome to reach out to me if you want to at melanie@hcbs.info. But the answer is, compared to comparable instruments, the consistent feedback we get is that it is very it's generally easier, it's generally briefer. InterRAI specifically avoids that sounds like avoids over assessment. So InterRAI tries to develop instruments so that they are minimum data sets that are comprehensive in nature. So it's kind of like, what is the basic that what are the basics that we need to know to make sure that we can develop a good care plan for this individual? And let's not go way into detail and over assess people in ways that are not going to be meaningful to them or meaningful to the development of the care plan. And so yes, from all of the feedback that InterRAI has gotten, all of the studies that have been done show that this is, this is a friendly experience as much as an assessment can be. And Tony?
Yeah, thanks, Melanie. I was going to ask, and I think this leads into Christine's other question about what makes this more person-centered. Is my understanding is that it's designed to highlight strengths, goals, and preferences rather than just seeing challenges and impairments. And so more of an interactive interview to get at some of those strengths and preferences, as opposed to just people as a collection of impairments or disability. And that seems to me to be why people would like it more and find it more person-centered. Fair enough?
I think that that's exactly right. And kind of along the same vein, we really are looking at a person's strengths, needs, preferences in a holistic way to really get a full view of that person. We're not only worried about their impairment in ADLs, right? We want to know how their complete situation impacts their life so that we can make sure that we're servicing them in the best way possible. In addition, the applications that I talked about, the scales and things like that, give us summaries that are easy to understand, right? So they can be translated in ways that are understandable for the individual too, helping them be a part of the process.
Thank you, Melanie. And then Lizaldi, you also had another question similar to Tyler's about being able to see the instrument in action. And we'll consider what, the options that Melanie has for us and come back to you guys with that. And see if there is a way for us to show that to you without breaking the proprietary, requirements. Is there a timeline yet? Cherry, do you want to take that one? Or
Sure.
I
Yeah,
can.
just got off mute there. Multi-year, that's all we can say. Multi-year, the planning stage, we're about to hopefully formally launch planning in the next month or so with CMS support. And that's going to take, another year's worth of time, to be honest. It takes a long time to procure a vendor. And that's I'm not hiding anything by saying that. It is a true fact. And so to even get a vendor on board, to even begin talking about designing their software to meet the InterRAI solution and our needs in Alaska. So multi-year, I think that's all I could probably guess right now is it's at least a year out for planning phases to be completed.
And if I
And
may add to that, Cherry, we've gotten 3 years of funding from the legislature. So that's the seed money in which I've told legislators we are going to go as far as we can go with that support. And then we'll see where we land. Well, I think one of the reasons it makes it hard to give you firm time benchmarks is that we, as Sherry said, we are working with a whole symphony of partners who are getting people are claiming for attention for all kinds of ways from our procurement office, from our IT office, from CMS, and not just one office at CMS, but a couple of offices at CMS. And right now we are working, one of the main tasks in front of us is to make sure we secure the federal support that the legislature asked us to go get. And as part of that, we need to present them with a time frame. And we are working with them on what that will look like. They're giving us thoughts that we need to fold into the time frame. And so that's what makes it difficult to be really specific about by this date we'll have this done and by that date we'll have that done. But as those things become more clear, we'll certainly be sharing them with all of you.
one other thing to mention to people is that we have been working with our partners at HCBS Strategies with Melanie, and also even before we began working with them, we as a state started researching and looking at software vendors before we ever want to go out for an RFI or an RFP, so that we would have a better understanding, because there's a waiting game sometimes with CMS and procurement. So we were trying to do as much as we could possibly do to figure out, what do we want? How would we write it into a contract or into an RFP so that we get a good system? So we've been doing a lot of work that we just you can't share people with that right now. But we have been doing the work. So just wanted you to know that we're not waiting, just sitting back and waiting. There's so much work in this project. It's crazy. Megan asks, for other states who implemented InterRAI, have you seen them reevaluate their current waiver regulations, causing them to modify, explore new services? Will this tool help identify supports needed that Alaska might not have, which may require some regulation changes? I will answer that one. So the tool itself doesn't actually identify supports that we might want to change as a state. The tool is limited to case mix and the assessment. Where I think that we could see some changes going forward, where it's far off down the path. Again, I don't want to go too far out there, but when we talk about resource allocation, and if we were able to assign budgets for individuals and create sort of more of a participant directed service, at that point, we could add in other types of services, perhaps, that would make it more flexible for people because they're choosing whatever's within their budget. That is far off and is going to take a lot of brain power for all of us, providers, recipients, state people, to really think about how we would do that in a thoughtful way, and just when that would happen. Like I said before, though, first we have to develop the assessment, make sure we have no loser people, no people that fall below the threshold that are currently receiving services. Then we have to gather some data and develop some of those caps and scales and algorithms that the state decides we want to use. Then we would have a way to perhaps build resource allocation and think about other services that might benefit people in the state of Alaska and allow us to be more flexible in our system, which is what everybody wants. But I encourage you to really remember we're in the very beginning phases of this project, and it will take at least a couple of years. But we all want the same thing, I think, and that we want flexibility for the people that we serve. And let's hope. I mean,
Yeah.
when I saw InterRAI in 2009, and I've seen it several times and seen across the continuum of care how other states have used it and how rich it could be for our state. That's what gives me excitement to think that, you know, it could turn the curve for us. And I don't want to overpromise because it is going to be a lot of work, but it also makes me so excited. But go ahead, Tony. Sorry.
No, I was just going to ask Melanie what she's seen working with other states in response to Megan's question about changes you've seen other states make in response to what they've learned through InterRAI implementation.
Well, I think that the last thing you said is key there in response to what they've learned. And so, you know, it's not like you do the InterRAI and then everything just falls into place, but it gives you a new way of looking at the people you serve. It gives you new information about them, really good, rich information that can help help flag where you might need new services, right? And so I do see lots of states that are using the data that they get to characterize their populations and understand, like, oh goodness, you know, we're serving a lot more people with severe cognitive impairment than I realized before. And goodness, there are a lot of them in rural areas. What can we do about that? And so it really kind of does, press policy folks to really think about these things that are there, but that they're now able to see, and they're able to see it clearly. And so really sky's the limit in terms of better understanding your population and how you can then use it to develop your program in such a way to serve them better.
And I would add to that, Melanie, like something as simple as like the fall risk. Identifying those individuals that are at risk for falls or have fallen. How can we better educate people, our DSPs or our care providers or the people themselves about in their own homes about how to eliminate falls? That's the part that is also very exciting to me because it builds health within our own communities. It teaches people about their own health or has the capabilities to do that. And I think that's really important as we go forward. We only have about 4 minutes left in our presentation. And I see no more questions in the chat, but anybody want to get a last one in? So great to see such a great big turnout. We really appreciate that.
We look forward to continuing to share information as we go through this project. Thank you so much to everybody for being here today.
Jonathan, I saw Jonathan might have lifted his hand. Was that just a salutation? Okay. Thanks,
Thumbs
Jonathan.
up, right?
Hey, Melanie, I have a question. As I walk around the Capitol and talk about the InterRAI, it doesn't exactly roll off the tongue easily for a lot of legislators. What is the InterRAI? Where does that name come from?
So it no longer means this. And so I cannot get into trouble because someone put in a recent study that it still meant this, and they got a stern talking to at the last big meeting. It used to mean International Resident Assessment Instrument, RAI, Resident Assessment Instrument. We've gone so far away from our institutional roots. We're no longer about residents, right? And so that's really why we went away from it as an acronym, but we still kept the name InterRAI. And so, yes, though, we don't have we need a backronym, I guess. We need to decide it means something new, but we haven't done that yet.
Okay, thank you. And thanks everybody for being here. I guess that'll wind it up if there's no further questions. All right. Melanie,
thank
thanks for joining SDS today and all of our partners in Alaska.
Thanks so much for having me.
Yeah, Lynn, Caroline, Kara, Cherry in particular, thanks. Thanks for your help pulling this together.
Thank you, everybody. We'll go ahead and close our session.